My name is Christine, and I want you to see me, and I want you to see NF.
My name is Joel, and I want you to see me and to see NF.
My name is Tyler, and my mom and I both have NF.
I was diagnosed with NF2 when I was 9 years old after I began having seizures.
Found I was a little girl. My grandfather hugged me. I think I was around 6, 7 years old. He found a bump on my arm.
It took a couple years for my mom to battle for me to see a neurologist.
In fact, I didn't realize how much I was keeping it a secret until I did my promotional work for my fundraising.
I hid it. You know, I would wear a lot of long sleeves, dead summer.
And also embraced my own form of it, which is schwannomatosis.
My biggest fear, even up to now, is for him to go through the pain that I go through. So far, knock on wood, he's good, he's 9. He does have cafe au lait spots, ADHD. It is important to make NF visible because of the way it affects everyone different, whether it may be NF1, NF2, schwannomatosis.
I had a tumor removed from the back of my leg in 2010. It left me with foot drop for over a year, but I did find a way to continue to run. Since then, I've run 14 marathons.
NF shouldn't stop us from pursuing our dreams, and to me, it doesn't. And others should know that just because we have a disease that is challenging, we can't succeed in life.
My mom is fire is that when she's in pain, she really doesn't complain, so she could keep me happy and not worried.
The spirit of this shirt is something people can't see directly and know what the source of my strength is.
It means that I was born with NF.
Strangely, this disorder, having this disorder, has shown me a strength I had not imagined I could have.
As an almost deaf individual with no hearing in my left ear and very little in my right ear, I'm trying to embrace the fact that I'm going to be deaf soon. And yet, this is another challenge, but I am going to overcome it.
Hello, everyone. My name is Gregory Lekovich. I'm a neurosurgeon. For those of you who don't know me, I'm in Los Angeles at the House Institute, where I've been for 15 years, where we've taken care of a large number of patients with neurofibromatosis, mainly neurofibromatosis type 2. I'm also a member of the Department of Neurosurgery at UCLA, where I'll be moving full-time at the end of the month, but I'll continue to be the co-director at House. So it's a real honor and privilege to have been invited. Thank you to the organizers for asking me to come and speak to you all. It's something that I'm very passionate about, and I hope the cases that I share with you today will be helpful to those of you in the audience who may be going through a process of decision-making of your own or are doing so on the behalf of someone in your family. And the goal of my goal is to give you an insight into the decision-making process that we as clinicians, especially, I'm a surgeon, so my presentation will be biased towards the surgical decision-making and the things that we can consider and we use when deliberating about the best course of action to recommend to our patients. And of course, there's a lot of overlap. And I have to acknowledge from the beginning that this is a personal approach. Unfortunately, as I'm sure you are all well aware, there is no settled or universally agreed upon algorithm or decision-making tree for many patients, particularly those whose tumors would come to be called complex. And since that's what I was asked to speak about, that's what we're going to dig into. And this is understandably difficult, I think, for patients and families, because they go from one expert to another and may get conflicting advice. And so understanding that that's part of the deal, I'd like to, again, share with you my own approach. And I think in these situations where the recommendations do vary wildly from one center or one expert to another, it's always been my feeling or my opinion, my experience, the best thing that I can do is try and be very transparent about my logic and my reasoning, and advocate for my point of view. I don't necessarily try and argue against another approach or anything, but just say, well, this is why I am recommending this. And that way I think a patient walks away from the interaction at least understanding where I'm coming from. And then they can go to another expert and they can hear where that person's coming from. And I think that helps. So that's what this talk is going to be about. But all of this really begs the question, what is a complex tumor? What does that even mean? Aren't all brain and spinal cord tumors complex? There's a little bit of semantics there. And I think, on the one hand, beauty, complexity is in the eye of the beholder, and what's complex for one person may not be for another. On the other hand, there's another quip that you may not know to define complexity, but you can recognize it when you see it. And so here you go. I made a complex diagram. I don't know if that will show on the screen as well, because some of the fonts is very small, and I wasn't sure how big of a screen we'd have to look at. But the idea here is I use this freeware software called Lucid, which is a mind mapping software. So I'll refer to this diagram through the talk as the mind map. And it's basically a diagram of the thought process, nonlinear thought process that has to take into account all the different things that we need to consider when we're talking about tumors. And particularly, how do we even define them as complex? What about this tumor makes it hard, makes it complicated? And in this diagram, you'll see a central oval. The things roughly to the left of the oval, on the left side of the diagram, are cognitive complexity, things where it's hard to decide what's going on or what to do. And on the right-hand side of the diagram is issues that make the action, once it's been decided upon, hard to execute. So that can be something that you could basically sum up as easier said than done. So that we'll go through each of these in more detail. So again, cognitively complex cases. Tumor could be complex because the decision-making regarding the tumor is very hard. It's unclear what the correct course of action is. Sometimes it's hard even to diagnose what's going on with the patient. Sure, we know that you have NF2, but that doesn't explain what's causing a foot drop, for example, which is a classic problem that we run into in patients who have more than one tumor, and we're trying to sort out, well, what is it that we need to address here to help you? Similarly, the complexity cognitively comes up all the time when we consider the alternatives to treatment. So again, I'm a surgeon, so I'm approaching this from the surgical point of view, and I think in the surgical community, amongst neurosurgeons anyway, NF2 is considered, quote unquote, a surgical disease. For the most part, most treatments, surgery is going to play a very positive role in most situations, or have a positive role in most situations. But there are alternatives, of course, and that can introduce complexity of a very serious sort. On the technical side, well, it's kind of easy to see as complex, I think, tumors that are very high risks, tumors that are very dangerous to remove, for example, or dangerous to treat. And that's sort of the easiest group to understand. But what about them makes them high risk is the next level question that I think we can answer for you. And in neurosurgery, we have a term called eloquence. And eloquence means speech, basically. And it comes from the left side of the brain, having nothing to do with NF2. But if you have a stroke in the left side of the brain, you can lose your speech. And so that part of the brain has become known as eloquent. And that term is then used, has been appropriated by every area of neurosurgery or even neurology to describe parts of the brain or nervous system that speak if they're molested or bothered or injured by a tumor or surgery or what have you. So a tumor can be eloquent because of that function, like it harbors speech or vision or hearing, or it can be eloquent because it's close to a part of the brainstem or critical neurovascular structures, arteries, what have you. And similarly, if there's a history of a tumor, something about the tumor itself being characteristic of the tumor itself being difficult, for example, a giant tumor or a tumor that has had previous surgery, so it's scarred, those can make the tumor high risk. And then there's situations, particularly in NF2, where there's often multiple tumors, and those multiple tumors can introduce all sorts of complexity. I kind of foreshadowed that a little bit when discussing a foot drop, but you can have tumors where what happens is you might have 2 or 3 small tumors. We see this more often being an issue in the brain than the spine, where over time they're observed and they coalesce into one conglomerate, which we call a collision tumor. And a collision tumor becomes very hard to manage from the perspective, in particular, of giving patients guidance as to what to expect, let's say, when you're talking about the risks of surgery, because we're not really sure which nerves are involved in the tumor if it comes late. And by definition, if we've been watching them as they kind of conglomerate into one aggregate, we know that all of those nerves will be at risk, and there may not be a visible border during surgery when we go from one nerve, let's say, to another. But there can also be situations where there's just a lot of tumors, and this comes up more in the spine. I call them grape clusters, or you could think of them as beads on a string, where there's a lot of maybe even small tumors that have just are occupying space, maybe a small space individually, but as a group, they occupy a lot of space. And then some of the more difficult ones to treat are what I call tandem lesions. And tandem lesions, I think it's my own phrase, by the way, but tandem lesions are ones where, again, to go back to the foot drop, a patient may have a brainstem tumor, a cervical ependymoma, and also a big tumor in the lumbar spine. And you're trying to figure out, okay, now what is the cause of the foot drop? This is really hard to figure out, and we have to try and be methodical, and I'll give you some examples of all of these. So that having been said, it's a very, very broad topic, as you can appreciate just from that introduction. And it would be impossible to go over every treatment option in every one of these scenarios. And so I'm going to stick with what I know. As I've said before, I'm biased towards the surgeon's point of view because that's what I am, and I think that's keeping with my philosophy what you should hear, and then you can go to another talk from an oncologist and hear what they have to say. And I think the format for this would be, in my opinion, the easiest way is just to go over specific cases. So these are real patients, sometimes longitudinal. You'll see patients I've taken care of for, in some cases, upwards of 15 years. And hopefully, by going through these stories, you'll come away with something valuable. So, putting aside my big introduction about complexity, I think there's a whole other way of looking at things, and maybe you're thinking that, which is, well, there's a simple answer to what's complex. What's complex is whatever's not simple. So this would be an example of what many would consider more straightforward. This is the classic NF2 presentation. This is entry-level kind of stuff. Bilateral vestibular schwannomas. I don't have a mouse, but if you look on the right side, which is at screen left, you'll see there's a tiny little dot of brightness in the what we call the internal auditory canal. The tumor on the patient's left side is more easy to see, but there's a little one on the right side. She was 14 when I met her. She had been diagnosed at 12. And when she was initially diagnosed, both of those tumors were the same size as the one on the right, just a little dot in the internal auditory canal. She had perfect hearing, really outstanding hearing if you look at those numbers. And she had has no other tumors that we know of. So this is what we would consider, as I say, that this is sort of the most simple or straightforward in many ways. And yet there's the background here is good hearing, growing tumor, And the growing tumor, it's grown a lot. It's 11 millimeters now. It was 2 millimeters just 2 years ago. So something should be done. Something has to be done, we think. And there's a discussion. The patient had discussion. The patient was from Pennsylvania. She had discussions in Pennsylvania. Some advocated for continued observation while she had good hearing. You know, it's a small tumor. It was not life-threatening, so it could be observed. If her hearing dropped, she could get Avastin. Avastin may control or temporize for some amount of time, may save the hearing on that side. Others advocate for radiation in this perspective. You know, we see a lot of kids that get radiation. The idea for radiation is to arrest the growth of the tumor, which is certainly growing, so that's indicated in that sense. And then maybe delay hearing loss. I don't think in NF2 it's really fair to say that radiation will provide long-term hearing preservation, but you could say that with some support from the evidence that would delay hearing loss. And these are very sound recommendations. And actually, this is a very common situation, which I'm sure you all know someone who's confronted. At the house clinic, we have a little bit we have an extensive history taking care of NF2, and we know that in NF2, we can preserve hearing in patients with small tumors. This is published maybe 15 years ago, or more than that, maybe 20 years ago now. And we know that the rates of hearing preservation after what we call middle fossa approach, or the above the ears, sometimes called by Dr. Google, we know that approach provides for patients with NF2 pretty similar hearing preservation odds in appropriately selected patients as what we call sporadic tumors, or the patients with vestibular schwannomas that are not syndromic. The downside of this paper, of this study, this is the only data that I'm going to show you, so don't worry. But the downside of this is that because this included a lot of pediatric patients, as we followed these individuals over time, there were many recurrences. A recurrence meaning the tumor comes back, even after the tumor was completely removed. And probably it's fair to say that the tumor actually isn't coming back, or maybe it is. It doesn't really matter, because with NF2, you're very likely to develop a new tumor in the nerve that was left behind. So again, it's different than a sporadic or non-syndromic tumor, in which when we are in the operating room and we see the borders of the tumor, we can be pretty sure that there is no other tumor. That's the border of the tumor that we see. But in NF2, we know, back from research that was done also at House by Fred Linthicum, that in NF2, we'll see microtumors that are only visible under the microscope in the affected nerves beyond what you can see grossly. So some people are kind of down on the middle fossa for that reason. They say, well, this is still just temporizing. And I think that may be true, but there are some patients who've gone 15, 20 years with no recurrence and with preserved hearing. And so we think that, even if you're talking about a 14-year-old girl, in my opinion, getting her through high school and college with good hearing and being able to tell her that with a very high degree of confidence, you're really delivering something that's important. So that's what we recommended. We recommended a left middle fossa craniotomy to remove that tumor, but preserve hearing, if possible, at least attempt to. And things went very well for her. This is her 2-year MRI. The tumor is removed. Facial nerve function is 1 out of 6, which is the House grading scale for facial nerve function. And the tumor on the right hasn't done anything, and her hearing is good. And I want also just to take this opportunity to mention that these tumors are harder to remove the larger they are. Not necessarily or only from the perspective of hearing, but also from the perspective of facial nerve function. And unfortunately, when you kick the can down the road with the best of intentions in an adolescent, you sometimes set them up for a problem later in life where they have a bigger tumor with a much higher risk of injury to the facial nerve, and they still have lost the hearing. And so I think as many of my patients get older, in their 20s and 30s, a lot of them, as the video the woman in the video was saying, she's preparing to lose her hearing. This is something that is, I don't want to say it's inevitable, but it has to be on your radar screen. But facial nerve function doesn't have to be put at risk, and certainly isn't always. And so we really want to think about people's quality of life in the big picture. Balance is another one that's very important for patients, of course, but that would involve usually larger tumors. So here we elected to do this, and the patient had a good outcome, and so of course that always makes makes us feel good about our decision-making process. And in reality then, in retrospect, this wasn't a simple case, and that's kind of why I threw it in here. This is the first of the complicated cases, because it is maybe the simplest or the most universal discussion to have with NF2 patients, but there's nothing simple about it. It's very, very hard. There's no wrong answer or right answer in making those decisions. There's lots of people do all those different options that I described for very good reasons, and I wouldn't say that that's a mistake in any of them. And that's what makes it so hard. So as I said, that was a case of cognitive complexity, and we'll talk about maybe a little more issues with that cognitive complexity and decision making, but also if you look at these diagrams, there's some, I put in some blue lines here, and this is supposed to be where they interact, and nothing is so simple to have just something that's technically complicated alone in a vacuum. There's always interplay between the left and the right-hand side of the diagram, just like there's always interaction between the left and right-hand sides of our brains. So the next couple of talks we'll be talking about eloquence, because eloquence is really, I think, the heart of the matter in us as surgeons and trying to figure out what makes something challenging to treat surgically. Eloquence in this circumstances, again, we're going to stick with sort of the more routine NF2 problem, which is vestibular schwannoma, right? So this is a 28-year-old from Seattle who has a what we call a giant vestibular schwannoma. Giant means it's over 4 centimeters in size. We know tumors that large are associated with higher risk, for example, of a facial nerve injury, which is important. He has good facial nerve function. He had surgery on the right and gamma knife as a kid, obviously years before. He also complained of poor balance. And the reason that this tumor is so large is because it was his only hearing ear. And yes, it was growing, but it was his only hearing ear. And for that reason, the clinicians, and we do this all the time, were reluctant to intervene on this. And it grew to the size where it is now, and he lost his hearing in the year before. So it was time to do something. But I would say for this, it's not cognitively difficult to decide what's going on, what we need to do. This is a huge tumor, a giant tumor, as I said. He's lost his hearing, so there's no way to preserve it. It's too big for a cochlear implant. There's not going to be a cochlear nerve there. So this is pretty straightforward. He needs what we call translabyrinthine surgery and a placement of an auditory brainstem implant. And so this is really a case of, as I said in the beginning, these are the technically complicated issues where it's difficult to execute on the plan, even when the plan is pretty easy to come to, so to speak. And he did well. We did leave a little bit of tumor. Again, I don't have a mouse, but I could show you on the screen. There's a little bit of enhancement on the left side, meaning that we didn't get 100% of the tumor out, but I think that's okay, given that we're not going to surgically cure him of NF2. It's much better to keep the facial nerve intact, which we were able to do. And we were able to place an ABI, and even with that large tumor, he was able to use the ABI usefully. He is a daily user, using it over 10 hours a day. And he was able to return to work. He works as a parking lot attendant for a rental car company, and so we were very happy with that. So again, that was a case of maybe on the mind map here of eloquence and eloquence related to a giant tumor. I'm going to talk about the next few cases, looking at just purely eloquent tumors in the brain and the spine. Again, since that was our mandate today. And we all think of NF2 as a disease that affects hearing, but it has been my experience that there's a fairly high percentage of patients who struggle with vision loss as well. So it's a canonical part of the diagnosis and workup for NF2 to consider cataracts. Cataracts may or may not really be that vision limiting in NF2, but there are other issues that come up. In particular, what are sometimes called hamartomas of the eyes. These are abnormally retained tumor within the vitreous, which is the jelly between the retina and the lens. And so, this young woman had what's called hyperplastic persistent primary vitreous. So she was blind in her left eye since birth, and right eye is the only seeing eye. And she had she was deaf from large vestibular schwannomas that required surgery. And she started to lose her vision in the right eye. and she was learning Braille. Her vision had declined to 20 out of 200. She was from Indonesia, actually, from Jakarta, I think, and super motivated young woman, unbelievably intelligent. She wrote a couple of books about her experience with NF2, which are to me super interesting. And the tumor hadn't really gotten any larger, interestingly enough. It was about the same size, but she had progressive vision loss. So this is, by definition, eloquence. And so any attempt to remove that tumor surgically is going to result in blindness. It's hard to appreciate maybe on that MRI, but the optic nerve, which is the nerve that goes to the retina that provides all the vision, the only vision that she has, is going smack dab through the middle of that tumor, which is probably very firm like a rock, and there's just no way to treat that. So instead we did what's called optic nerve decompression, and we do that sometimes. Decompression is a term that we use in other parts of the skull and brain as well, where the concept is to make room for the tumor. We think that the tumors cause dysfunction in the nerves by putting pressure on them, by pushing the nerve up against bone. So by taking the bone away, you give the nerve some breathing room, and then we can, in this case, radiate with gamma knife, which might also cause a little bit of swelling. So it was good to do the decompression first to make sure that if there was any swelling, we wouldn't have precipitated a much greater loss of vision. And this strategy actually worked very well for her. 5 years later, her vision improved within a matter of months, and at her 5-year follow-up, her vision was 20/70. And so we're very happy, as you might imagine, she was as well with that outcome. And the tumor remained stable. So parenthetically, I'll just take this opportunity to say that there definitely is a role for radiation. Nowadays I don't do gamma knife anymore, but I do cyberknife, and there is a role for cyberknife or gamma knife for radiosurgery in the management of NF2. I think there are, in the journal Neurosurgery, there's a consortium of radiosurgery centers, international consortium, and they just published in rapid fire several articles on NF2 meningiomas and the use of radiosurgery. We participated in that study, and I think there's good evidence that there's efficacy, particularly for meningiomas with radiation, as in this case. But I think there are also risks, and unfortunately the risks are sometimes downplayed or hard to see because they can occur so many years later, and there's not been really, I think, good follow-up. And in particular, there's a recent neurosurgery article talking about malignant transformation and something about 270 patient years, and you may have come across this in your conversations with physicians. I think there's serious limitations to that study, and we'll come back, we'll visit that topic again. Another inherently or intrinsically eloquent tumor is something called ependymoma. Ependymoma is a tumor of the spinal cord, in the spinal cord. By definition, therefore, it is very, very eloquent because the spinal cord controls all movement and sensation to your body. So if you think of the spinal cord is basically a bunch of cables that are running from the brain to the limbs. If those cables are interrupted, the limbs no longer work. Fortunately, most ependymomas in NF2 are very different than non-syndromic ependymomas. They tend not to grow so rapidly. It's pretty rare, actually, that we have to intervene on them. We do sometimes have to, and I'll show you. But there always is risk associated with these tumors. And in my experience, basically, most likely subpopulation of patients to have issues with ependymomas are adolescents. If you make it through adolescence into your 20s without the ependymoma being very active, it's pretty rare that they continue to grow or to continue to cause problems. And this is a very high ependymoma at C2-3. This is a risk to the patient of quadriparesis, meaning weakness of all limbs, being severely impacted with mobility. And as you can see on the right-hand picture, which is called T2-weighted imaging, which is fluid imaging, there's a bright cap above and below the tumor. And that's a good sign for us surgically. That means that the tumor has made a little bit of a fluid space around the tumor itself, so when we enter the spinal cord, we can remove it more safely, and that's what we did. The tumor itself, you can see in the photograph, is actually a firm, rubbery nodule, and so pretty easy to differentiate from the spinal cord itself, which has more of a creamy texture. Similarly, this case is a patient of a 46-year-old. Again, this is pretty uncommon in my practice to operate on someone this old for ependymoma, but he had progressive issues. He also had a prior history of spinal surgery, so it's always hard again to determine what is causing his deficit. As long as it could be the cord, we have to understand and take that into consideration. And this was a much smaller tumor, I think fairly lower risk surgically from a surgical perspective. And I've included a couple of pictures here, and you can see what I was talking about before. There's a good differentiation between spinal cord. Again, I'm sorry, I don't have a pointer or mouse, but you can see normal spinal cord, and then on the left side, left panel figure, we're just entering the cord. And on the right panel figure, we've entered the cord more widely. It opens up like a book, so to speak. And there inside in the middle, you can see the tumor, which is clearly demarcated from the normal spinal cord. It looks very, very different. And we're able to remove that safely without causing any new deficits. Other types of tumors in the spine occur much more commonly than ependymoma, although ependymoma itself is quite common. And those are what we call extramedullary. So medullary in this context means in the spinal cord itself. So if it's extramedullary, it's outside the spinal cord. It can still cause problems by compressing the cord, and most often these are schwannomas. We do see meningiomas in the spine too, but most often they'll be schwannomas. And then typically, these are not complex tumors to deal with. The schwannomas in the spine can be removed, even large ones with very low risks of injury. It's usually pretty straightforward, but there are, of course, exceptions to the rule, and that has mainly, again, to do with eloquence. So we had a patient, this is one of the very first patients I took care of, who came to us from India. She was 19 years old. She had completely lost her mobility, and she had a very large tumor on the left side, larger than the one that you see remaining on the right side. So she came to us for her vestibular schwannoma removal, and she did very well from that. But about 2 weeks later, she showed up in our emergency room almost completely paralyzed. And so we scanned her neck, and we saw this large tumor at the junction of the brain and the spinal cord, which had become, for whatever reason, all of a sudden very acutely symptomatic. And we see this actually. This is I don't know if you know anyone who's had this phenomenon. It doesn't happen all the time. But we'll see some kind of shifting or settling of these tumors when we remove a really large tumor. And so it's not that uncommon that we move a vestibular schwannoma, for example, and then the patient all of a sudden will have that foot drop from a spinal tumor, which had somehow been balanced against the vestibular schwannoma in such a way that it wasn't causing symptoms prior. So we kind of knew what was going on immediately. And the reason we didn't know about this tumor beforehand was because her workup had been abroad, and we went into it a little bit blind, unfortunately. But we were able to remove this tumor really without any complications. And the patient sent me a very lovely letter, which, from a surgeon's perspective, these letters are worth their weight in platinum. I mean, it just means so much. But she sent me a very nice letter saying that she could write this note and she could walk again, and so that was, again, something very gratifying. And then, as I said, there's these situations with these spinal tumors where you get multiple tumors that kind of, just by virtue of the fact that they're like a cluster of grapes. And you'll sometimes see on MRI reports where the radiologist will just get exhausted from trying to describe the MRI, and they'll just say too numerous to count. There's so many tumors in the spine, and this is typically in the lumbar spine, most commonly where we see this, and that's exactly what's going on here. This is a 17-year-old girl from Texas. She's an athlete. She's playing tennis, and her tennis she was having a hard time because of back pain and leg pain, which is sort of an old person's complaint, right? That's lumbar stenosis. She was having lumbar stenosis complaints, no nerve root problems, just pure straight up compression of all the nerve roots by these tumors, and so she needed surgery. And so when I first started, I was very reluctant to be too, what we call aggressive, I wanted just to not court additional danger and just treat the immediate thing that was causing a problem. And as I've gotten more experienced or older or whatever, and as we've gotten better technology, I think that's not necessarily the best thing for patients. When it's safe, and certainly, again, these tumors are not inherently technically challenging to remove. Her main tumor was at T11, so at the bottom of the rib cage, where there's a lot of relative eloquence, so that we had to treat. But you'll see with ultrasound, so that the grainy image with the snow kind of flake pattern is an ultrasound picture. We're able to, before we open the dura, make sure that we can see all these different tumors. And I'm sorry I don't have a mouse, but you're looking on the screen here. There's one large dominant tumor towards kind of the right-hand panel and another little one. And in fact, we removed 8 tumors, and you can see on the back table from the operating room, we removed 8 tumors at one setting from this patient. The idea being she's 17, she doesn't want to come back to the operating room every 2 years for spinal problems. While we're there, why don't we try and kind of scrub it clean as best we can, as long, again, with the proviso that we're not incurring unwarranted risks. And again, that worked in that circumstance. So those were tumors, eloquent tumors. This is sort of all the situations that we discussed so far have been solitary tumors that, by virtue of their size or their location, were very dangerous. Or we talked about the spinal tumors that sort of grape clustered. Now we're going to kick it up a notch in terms of our complexity of decision making and complexity of problems, and I'll finish with a couple of cases more. And this will maybe illustrate a way that both the left and right-hand side of the mind map have to kind of work together. So that would include tumors that are high risk, in eloquent areas, giant, but they're not alone. There may be 2 giant tumors next to each other. They may be colliding. They may be in tandem locations. There may be poor options, or the patient may have exhausted other options. So we can really kind of light up the entire map here as we go along. So I'll give you an example of what I mean by these tandem lesions and the uncertainty, diagnostic uncertainty. And I've already shown you the same patient. This young man was the guy from Seattle who had that giant tumor on the left side. But it turns out that his presenting symptom was imbalance, and he had also some right upper extremity weakness. So when we see the tumor this big, we think imbalance. Well, that's going to be from the acoustic, most likely, in the amount of compression that's on the brainstem. But he also had a brachial plexus tumor. Well, maybe that contributed to his upper extremity weakness. Doesn't seem relevant to balance. But here we found also a large ependymoma. So this is, again, the same ependymoma that I showed you before, but this one is at the craniovertebral junction, really in the medulla oblongata. And that makes things, of course, very, very high risk. This had been stable. So you can see when we're looking at this now, we've got everything lighting up at once. We've got tandem lesions, a large acoustic tumor, and a large and very eloquent brainstem tumor. On top of that, we have other tumors that are growing and active in this patient that can be causing him morbidity outside of the spine. We have options that we have to consider for him, given the amount of surgery that he was looking at having to do, if this was all going to be treated surgically. So we needed to discuss those with him as well. So as I already told you, we treated that left vestibular schwannoma surgically. We had a good outcome with that. While that was going on, he had other things brewing. And this is a very important aspect of the decision-making that comes up when we have these tandem lesions. I call it prioritization. Unfortunately, it can be like a game of whack-a-mole, and there's things popping up all over the body. We've got to deal with the number one problem, and that could be sometimes not even the one that we think is most likely causing a symptom. So if you look at the 2 symptoms that we described, imbalance and arm weakness, probably the arm weakness is from the brachial plexus tumor. Most likely that would be, if I had to guess. But we don't know that for sure, and the other ones are much higher risk to him. So even though the symptom might be what's driving the patient's concern, we've got to make sure that we don't put out a campfire when there's a raging forest fire that we have to deal with. That's a higher priority. In general, my rubric for this is brain is going to take priority over spine, and spine will take priority over peripheral nerve. But in any event, you have to look at both the tumor's behavior and the symptoms and come together with a synthesis. Now, while we were dealing with that vestibular schwannoma, this ependymoma had increased a little bit in size. And we were pretty comfortable that given the chronicity of the appearance on imaging, that again, the vestibular schwannoma being in the brain was, and being so large was the greater issue. Soon after we removed the vestibular schwannoma, I had recommended that we remove the ependymoma. And the patient ended up having removal closer to home, which is, it's very hard for a lot of people to come to LA for everything that they need done. But at the other institution, they were just able to drain that cystic part. And so the patient felt better. His balance got a little bit better after he removed the vestibular schwannoma, but he still had balance issues. He still was using a walker. After he had the cyst drained from the ependymoma, and he had a lot of decompression of the bone around the craniovertebral junction, he felt a lot better. He was able to walk around and stuff. And so I thought, well, okay, well enough alone, we'll see what happens. That's, in my experience, not been a great way of dealing with these because the cyst can just fill up with water again. And that's exactly what happened 2 years later. Now the thing is much larger. And the issue here is, unfortunately, when you do something with the best of intentions, sort of kicking the can down the road, the problem when it comes back is twice as bad. So now, yes, he's had a decompression. He didn't really have symptoms until the cyst is much, much larger. And that, of course, means that the brainstem has been stretched that much thinner. And that makes the risk of treating this that much greater. But it is what it is, and we at this point, he understood that tumor had to be removed. And again, here you see on the left-hand side, there's another ultrasound from surgery. And you can see how we're able to use the ultrasound to really define in the operating room the borders of brain and the tumor. I was able to remove the entirety of the ependymoma. You can see that his brainstem was at points stretched thin. It doesn't quite show on the MRI as vibrantly as in surgery, but it was transparent in some places. And he has some numbness of his legs and arm because of the way that we have to enter the spinal cord, but was able to recover essentially to where he had been beforehand, thank God. And he did, we continue to follow him. Didn't help his arm weakness. And we ended up having about maybe a year later to remove this large brachial plexus mass just to kind of finish things up. So again, tandem lesions, brain over spine over peripheral nerve. Recognizing that, like in this case, some of those symptoms had nothing to do with the brain or spine. It was probably the brachial plexus tumor, but we dealt with them because of the priority. In the last case, I'll try and race through, but it'll be hard, is a young man that from New York, from Manhattan, who I took care of for 14 years. And he presented at first to our clinic in 2009. He was 19 years old. He'd had radiation to bilateral schwannomas as a kid. To the right side as a kid. He had a fractionated treatment. He had hearing on the left side and a growing tumor. And so this is, again, a classic situation where we're reluctant to remove those tumors because it's the only hearing ear. But we had recommended that at this point. We were worried about his overall quality of life and the other health risks that he'd incur. He was a first-year college student. So this is that left-sided tumor. He elected to have radiation instead, which is, again, there's no right or wrong answers, and he was worried about losing his hearing. We told him up front, with a tumor this size, you're going to lose your hearing, and we'll put it in ABI, and he said, I'd really rather take my chances. Unfortunately, so this is this case will start off, and I'll show you how the mind map, all these things get recruited over time. In this case, that's a pretty straightforward question. It's kind of similar to the first case that we discussed, really one of complex decision-making only. Unfortunately, 2 years later, he came back with explosive growth, really, really rapid growth of a meningioma. And the meningioma had surrounded the acoustic tumor. So the meningioma started from the top, and where the acoustic tumor was growing out like an ice cream cone towards the brainstem, the meningioma kind of grew around it and surrounded it. So this is what we call a collision tumor. And you can see that here, where if you look at that, you can actually see the difference in MRI and brightness. You can still see that there's an acoustic tumor in the middle of that mass. And he still had hearing. He still had good hearing. And he's a college student. So what do? So we can't ignore this tumor because of its rapid growth and how much it's, again, jeopardizing his life at this point. So, but we work with the patient, and he, and he didn't want to lose his hearing, and he'd already kind of gone down this path with radiation. So we said, here's the acoustic tumor. We think we can see where its borders are. We'll remove the meningioma and leave the acoustic tumor. And so that's what we did. We removed we did a hearing preservation surgery called combined petrosal approach. His hearing was stable. We were able to remove most of the meningioma, but we weren't able to remove all of it. And partly that was because we were fighting with one hand tied behind our back because we were trying to save the acoustic tumor, and it blocked our access to some areas of the tumor. And that unfortunately proved to be a decision that had big consequences. Because although he did well and he went back to college and if you look at this picture, you can see in the upper left-hand corner was his 2009 MRI with just the acoustic tumor, and then the middle panel is when the collision tumor occurred, and then the right hand is after surgery that we did in 2009. In 2012, he's going to come back. And so what was at first relatively simple, complex but limited to this cognitive area, now starts to encroach upon the entirety of all the ways that we have to engage all our resources to take care of him. And this is what he came back with. So he came back with a tumor that now that we had drilled out all that bone, we had decompressed, we made a huge space for this tumor to grow into. When he finally came back to us, the tumor was 8 centimeters in size, which is about the largest tumor that I've ever seen or dealt with. And he lost his hearing during that time period. So still college student, still doing very well functionally, but now was ready for us to remove the whole tumor. Well, this is a very, very technically challenging tumor to remove just because of its size and because of how much it interacts with the whole brain. So I have a little video here of sort of a 3D reconstruction with the tumors shaded in red. And you can see towards the front there's the nose and eyes. And as we go on, this is a tumor that's touching the oculomotor nerve, the trochlear nerve, the trigeminal nerve, the abducens nerve, the facial nerve. Every nerve is going to be impacted by this tumor, and the brainstem, and the temporal lobe, and the cerebellum. So this is, for us, very challenging. This tumor took 30 hours of surgery to remove. It was spread over 2 days. But he did well. He did well. He was walking post-op day 2. And yet we still weren't able to remove all of it. We intentionally left some tumor in what we call the Meckel's cave and cavernous sinus because the facial nerve can't survive this surgery. Facial nerve was removed and grafted with a new graft in the neck. But the fifth nerve we actually saved, and the fifth nerve provides sensation to the eye. And one of the things that we try to avoid, again, this is sort of getting into the weeds of these decisions, is having an insensate eye that doesn't close well, because that will tend to cause problems with the cornea long term, something called neurotrophic keratitis. It can cause vision loss in that eye. So we left some tumor there because we were worried about the implications for vision loss. Is it okay if I go over a little bit?
I think it's working. Yeah. Sorry, why don't you finish up your talk, and then I'll just let everybody know we won't have time for Q&A here. But if they put their questions into our event app, Dr. Lekovich, I can follow up with you to make sure that those get answered.
Yeah, absolutely.
Thank you. Thank you.
So, so we left some tumor behind. Pathology showed that this was grade 1, and we started to think at this time, well, there's something going on with the radiation treatment that's made this tumor behave in this way. But no, the tumor was benign. So we continue to follow him. Again, every point under the sun that we have to consider for his management. Unfortunately, that tumor that we left in the cavernous sinus in Meckel's cave came back about 4 years later to us. In the interim, he's had Avastin, he had RAD-001, he'd had a third clinical investigatory trial. He really had been exhausting all his options because these are huge surgeries, and it was a lot for him to have to confront. But now it's a 6.5 centimeter tumor. Again, we take him to surgery, and we were able to remove it. The surgery itself was uneventful. He did well. He was discharged. But again, we had to leave some tumor behind. We couldn't get every last bit of it just because of how far it had gone. He had upfront radiation to that tumor, and I think this was a controversial decision. It wasn't something that I was super crazy about, although I understood the thought of it. He just, we knew that there was tumor left behind, and this tumor had kept on growing, and so he had Gamma knife actually to that cavernous sinus residual. Again, there's no right or wrong answer. All these different points that we have to consider. Unfortunately, in 2021, it occurred again, and now it was growing out of his skin, and had been biopsied in New York, and it was now grade 2. Grade 2 tumors can be removed. They're one step towards malignant transformation. he wasn't given any options locally, so we did take him to surgery. We were able to remove the tumor. We were able to get, but again, not all of it, we were able to remove the bulk of it and get a primary skin closure. Unfortunately, the pathology was not grade 2. This was a sarcoma. This had converted from a benign tumor to a full-blown malignancy for which there is no surgical cure, and there's really, frankly, very, very poor options, even with chemotherapy or radiation. He had a prolonged hospital stay. He had been pretty bad nutritional status beforehand, but he did okay. He was in rehab with us. He stayed through New Year's and was discharged home. New Year's Eve we spent together with his dad, and I asked his dad beforehand, hey, can I use this photo of Alan's? And he said, yeah, of course. But unfortunately, it's not a curable disease. So at this point, the tumor came back pretty rapidly, and the wound broke down. Further radiation was not recommended by radiation oncology, and Alan succumbed to this disease. So in summary then, I know I ended on a very discouraging and serious note, but I think that the things here is reflective of what we're dealing with. We're trying to think about things that can happen 15 or 20 years later. It's very, very hard. And I want to stress there's no right answer or no wrong answer. I'm not suggesting that anything was done wrong in his care. But we try and we have to have that huge picture view, and I think there's a role for surgery. For the most part, hopefully there won't be in 10 or 20 years. But right now, we really need to be involved in these decisions, be the surgeons. And I think I can take a stab at making a definition of complex now. I can say that complex tumors are those that require a lot of deliberation and decision making, or those for which the execution of a treatment is difficult to achieve. In every circumstance, though, in all this process, it's important that we, the physicians, and you, the families and patients, work together, because without understanding of the mutual expectations, not having a set, mutually agreed upon understanding of what we're doing and why, we'll never be successful in the long term. So anyway, thank you for your patience. I'm sorry I went over.